Next up, we're going to talk about critical pathways for the assessment of anticoagulants in the bleeding patient. Oftentimes we're presented with a patient who's bleeding. We may not know what anticoagulant they're on. We may not know what time they last took their dose of anticoagulation, and this ends up being a clinical conundrum for us. To discuss this is Dr. Nathan Connell, who's a wonderful colleague and will lead us through this issue.
Good evening. Okay. So I have no conflicts of interest to report. I'm going to be talking about off-label use of three medications, TXA, Amicar, and desmopressin. And what we're going to cover is try to bring together some of the previous talks to give you a sense of what to do in the moment in an algorithmic approach. We're going to go through the pathways for assessment and management of bleeding. We're going to talk about tests of coagulation and which ones may be useful in the acute setting when you don't know what a patient is on or when they last took it, or if there is a clinically significant drug effect. And then lastly, go through some supportive measures that you can try in addition to the reversal agents outlined previously. We're going to start with this case, a 63-year-old woman on anticoagulation with warfarin. She had an unprovoked pulmonary embolism in 2017, and she comes in with melena, and she's tachycardic and hypotensive. She has a 4-gram hemoglobin drop from her baseline, and her INR is read at 2.5. And while Dr. Connors mentioned that hematologists can't go through a talk without talking about coagulation and the cascade, this is why most people start to shut down when they hear us talk about coagulation. It's because this is probably an oversimplified version of what actually happens in all of our bodies. And what we're trying to do is pull out key pieces of this. And so I'm going to give you just a quick refresher on the coagulation cascade before we go into the test and how I remember it. Important things to remember is 7 is extricated from the rest. You look at the common pathway, 10 divided by 5 is 2, and you start on the other side and count at 12 and start backwards. 12, 11, you already have 10, 9, and 8. And the PT is on the side with fewer numbers. If there are fewer letters in PT as compared to PTT. So just once you get everything into the right place, you start to think about where these tests can be useful. And so this is what we're trying to do. We're trying to take out this tiny piece of the coagulation cascade and start to pull pieces of it with our laboratory testing. And so this gives you an idea. If you have both a normal PT and PTT, you have at least these coagulation factors that are intact. If you have a normal PTT, but you have a prolonged PT with INR, you can start to say, well, at least the common pathway is probably intact because that's part of the PTT, but we're really going to focus on just that one piece in the extrinsic pathway. So in looking at these tests, you have to remember that when we do these assays in the coagulation lab, we're taking blood and we're putting it into a system that is not actually the system that it has to deal with when it's going through a blood vessel. But we try to simulate it to some extent. We add calcium back in, we do all these things. But we're starting a reaction and we're following and seeing how long it takes to form a clot. That's why these tests are measured in seconds. And so the PTT, or the PT as you see here, starts really up at the top with factor 7 and tissue factor coming together in a complex to then activate the rest of the common pathway. And where you're ending is the creation of a fibrin polymer. As opposed to the PTT, which is starting all the way up with prekallikrein and high molecular weight kininogen and going all the way through factor 12 and down to through the common pathway to factor 1, fibrinogen. When we look at the thrombin time, now this is a test that is more readily available than most people think. A lot of labs can do thrombin times, but it is not necessarily as widely available as a PT and a PTT. Thrombin times are helpful because it really starts to get at what can thrombin do? Can it convert fibrinogen to fibrin and go down the rest of that pathway? This is very sensitive to the effects of antithrombin, and so heparin is going to be exert a pretty large effect on the thrombin times. So that's all I'm going to show you in terms of coagulation pathways. Now we're going to dive into how to use these tests. And so when you're faced with a patient that's bleeding, it's very helpful to get a prothrombin time and the activated partial thromboplastin time, PT and PTT, so we can see which pieces of the coagulation pathway are intact. There has been a resurgence of trying to limit certain tests in certain scenarios, and one of the things we commonly see is people getting one or the other as an initial screen, and you really need to have both to look at that pathway. A fibrinogen is helpful. You have to remember the fibrinogen is at the bottom of both of these pathways, and if you have a low fibrinogen level, both the PT and PTT are going to be prolonged. We're going to ask for serial blood counts. We want to see how quick the patient is bleeding and look at this hemodynamic instability. And if you have access to specialized assays, they can be helpful for allowing you to decide, is there a clinically relevant drug effect on board, or has it been so long that this patient has been off of drug? Maybe they took it yesterday morning, maybe they forgot their evening dose. Do you really need to go through the process of reversing something that may not even be on board? And so a lot of what I'm going to talk about in the next few slides actually comes from this consensus pathway published in the Journal of the American College of Cardiology in 2017. Remembering that in 2017, the reversal agent for apixaban and rivaroxaban and andexanet alfa was not approved at that point, but does have a role in reversal. And so the first thing that you're going to do is assess and identify the severity of the bleed. And the decision pathway says, is there bleeding at a critical site? And we're going to go through that in a second. Are they hemodynamically unstable? Or do they have clinically overt bleeding with a significant drop in hemoglobin? Or are they so dynamically unstable that you have to actually administer red cell transfusion? If any of those apply, this is considered a major bleed, and you start to go down that pathway. If all three of those are negative, it's considered a non-major bleed. So what are the critical site bleeds? Intracranial hemorrhage, you've heard a lot of us talking about that so far. Other CNS bleeds, patients with pericardial tamponade is considered a major bleed. Airway, particularly if it's posterior airway, as you're running the risk of airway compromise. Hemothorax, intra-abdominal bleeding, retroperitoneal hematomas, you can hide a lot of blood in these retroperitoneal bleeds, and patients with extremity bleeds that are compromising vascular or neurologic function. So you've gone down this pathway. You said the patient has a major bleed. Is the bleed at the critical site or life-threatening? Stop the oral anticoagulation and institute appropriate measures to control bleeding. Local hemostatic measures, surgical intervention. These are the patients that are probably going to benefit the most from administration of a reversal agent if one is available at your institution. If the bleed is considered major, but it's not at a critical site or life-threatening, you can stop the bleed and just institute local hemostatic measures, monitor the patients, and see how they do clinically. If we're on the other side, again, that's going back to this and saying that none of these areas apply and you've got a non-major bleed, well, does the bleed require hospitalization? If not, if there's no intervention that you need to do, you may actually be able to continue that anticoagulant and just advise patients of what measures they can take. So for instance, I have a lot of patients who report epistaxis in the winter, and you start to dive down into that history and you find out it's when they blow their nose in the morning and they've got some blood there. You can talk about humidifiers, nasal saline, and for women who are having heavy menstrual bleeding, you can talk about maybe holding the dose on the first day of the menstrual cycle if that's when they're having the heaviest bleeding. If you do have to hospitalize these patients or they need a surgical intervention, it's okay to stop the anticoagulant and institute these appropriate measures. And what are these? Well, we're going to get into them in a second, but it's also important to think about once you've stopped a medication, well, why were they on it in the first place? What is the reason that they needed this medication? And on a day-to-day basis, you're thinking about what is the biggest risk to the patient right now? Are they at a higher bleeding risk because of this acute episode, or are they at a very high thrombosis risk? If the bleed occurred in a critical site, or the patients are at high risk of rebleeding, you may want to delay restarting anticoagulation. If the patient had a provoked thrombosis, 3 years ago and they were just continued on their anticoagulation, and you go into the history and you realize that maybe they don't even need to be on anticoagulation anymore based on the current guidelines, you can actually stop that anticoagulant. It's also important to think about the fact that patients have preferences and values when it comes to their anticoagulant. They're the ones that have to live with the outcomes of the decision, and so it's important to start involving them in the decision-making process. So we're going to talk about that a little bit more later. When you do have specialized assays available, you can start to get down to specific drugs and what may be helpful in the lab. So for dabigatran, remembering that dabigatran being a direct thrombin inhibitor, I mentioned the thrombin time is very important. You can look at dilute thrombin times, which are not as widely available. If the dilute thrombin time is normal, it probably excludes clinically relevant levels of the drug. You can actually use the dilute thrombin time to try to dose titrate in some cases. With apixaban, edoxaban, rivaroxaban, again, these are 10A inhibitors. We're all very familiar with the use of anti-10A assays to monitor low molecular weight heparin and fundaparinox. If the 10A is completely normal, you've probably excluded a clinically relevant drug level. If you have calibrated assays, and this is the big caveat, they have to be calibrated to the individual drug of interest. You can actually dose titrate these medications. Most places do not have these, or if you send them out to the few labs that do offer calibrated anti-10As, it can take a very long time to get it back and may not be as helpful. There are some research reagents available, and this is starting to become more available. But the question is, what do you do when you do not have these specialized assays available? Well, dabigatran, again, many places have a thrombin time available even if they don't have anything other than that and the PT and the PTT. For dabigatran, a normal thrombin time excludes clinically relevant drug levels, and if a PTT can also be helpful in this regard. For apixaban, a normal PT and PTT do not exclude clinically relevant drug levels, so it's important to recognize that patients may actually have clinically relevant drug on board and yet have normal coagulation. With edoxaban and rivaroxaban, that is also the same case. The PT can be helpful if the patients do have a therapeutic drug level. The PT is oftentimes prolonged in both apixaban, edoxaban, and rivaroxaban. So what are these critical steps in anticoagulant-associated bleeding? First, stop the oral anticoagulant. You've heard us say that over and over again, and it's because we see these medications being continued in patients that are having bleeding and are admitted to the hospital for bleeding. If they're on a vitamin K antagonist, consider reversing the effect of this by giving vitamin K, 10 milligrams or 5 to 10 milligrams intravenously. It's important to recognize that it is a myth that vitamin K makes you hypercoagulable. It returns you to the baseline coagulable state that you had before you started the vitamin K antagonist. So you're not going to overshoot and induce a clot because you gave vitamin K to reverse a clinically significant bleeding event. It's important to provide local therapy, manual compression. If you see an area that's bleeding, you can apply pressure. We do bone marrow biopsies on patients that are on anticoagulation. We do all sorts of procedures, and we say that you're going to have to hold pressure longer at the site, and you may have a little bit more bruising, but it's important to recognize that these are adjunctive measures. You can transfuse patients. You can use antifibrinolytic therapy in many of these cases. And consider holding antiplatelet agents. So there's some patients who do have an indication to be on it, but many patients do not have an indication to be on anticoagulant and antiplatelet agents, as Dr. Ruff mentioned earlier. And look for comorbidities. Are these patients who have thrombocytopenia? Is there a need for platelet transfusion depending on the level of their platelet count? Are these patients uremic, and can you go through the use of Ddavp and try to improve the bleeding, or these patients with liver disease in which they already have a disrupted coagulation system at baseline. And surgical and procedural management of bleeding sites if needed. Always use that as a backup if there's a bleed that you cannot address. So I put up here about vitamin K again. It's very helpful, 2.5 to 10 milligrams. You can very quickly reverse the anticoagulant effect of the vitamin K antagonist. Oftentimes, a significant reduction in the INR within a few hours. You can use it orally as well. This will, in patients who have elevated INRs and maybe mild bleeding, this should reduce your anticoagulant effect within about 12 to 18 hours. We see this ordered subcutaneously. There's variable absorption, and intramuscularly I teach the residents, if you had an INR of 12, do you want somebody sticking a huge needle into one of your muscles? And they all of a sudden get why I don't like them to order IM vitamin K. Antifibrinolytic agents. I think these are underutilized in some of our patients who are having bleeding. We actually like to use tranexamic acid and aminocaproic acid. It's important to recognize that both of these are off-label indications. They work differently from some of our other agents in that they allow the hemostatic clot, once it is formed, to remain in place. And so this actually blocks the fibrinolytic pathway. So once you get that clot, it gets a chance to become stable and help with hemostasis. It's very useful in mucosal bleeding, particularly in the oral mucosa, but there are other places in the body. There's high fibrinolytic activity. And there are a bunch of different dosing schemes. And so I end up looking up a lot of these when it comes time to use them. You can use it intravenously based on weight and giving a bolus and then followed every 6 to 8 hours. You can do it by continuous infusions. You can give it orally. It's important to recognize that particularly aminocaproic acid can cause a lot of nausea in patients, and so I tend to like to use IV continuous infusion if I have to go that route. You also have to be cognizant of renal function in these patients and dose reduce as needed. Aminocaproic acid, 2 grams IV every 6 hours, and you can escalate this dose. Some of our patients have uremia, and it's important to recognize this leads to platelet dysfunction. It's hard to measure this. You can see some of this effect on platelet aggregation and platelet activation, but that's not widely available in many of our centers. Ddavp, desmopressin, increases plasma levels of von Willebrand factor, factor VIII, and tissue plasminogen activator, and it actually shortens the PTT, and so it helps with platelet activation and aggregation. The dose is depending on where you're using it. The Canadian dosing guidelines recommend a maximum dose of 20 micrograms. US, again, this is off-label here, and this is based on data from the 1980s. It's also important to remember as we use Ddavp in a lot of other indications, there's a risk of hypotension, hyponatremia, flushing, and a lot of fluid retention, so it's important to be on the lookout for that. So that previous pathway that I brought up brings us to this point. You have these patients, depending on if they're on a vitamin K antagonist, a direct thrombin inhibitor, or a factor Xa inhibitor. In many cases, you'll see the 4-factor PCCs being used here. For the direct thrombin inhibitors, you've also already heard Dr. Connors talk about idarosizumab, but if that's not available, going down the route of the 4-factor PCCs. For the factor Xa inhibitors, again, this was published in 2017 before approval of andexanet alpha, and so that would be at this point in patients who are having critical life-threatening bleeding with a recent dose administration, it is appropriate to use those agents, but you can also use 4-factor PCCs. So 4-factor PCCs are much more widely available now than many of the reversal agents, and so it's still going to be a go-to for us. And when we restart anticoagulation, again, once you've gotten to the point, you've gotten through the bleed, you've managed that, and patients are clinically stable and ready to go home, ready to restart anticoagulation, you got to think about the timing. Is this something that is so critical that they restart anticoagulation while they're in the hospital? You're going to watch them. Is this something that you're going to give them a few weeks because their indication for anticoagulation doesn't necessitate immediate restart? Think about where they've had their sites of bleeding so that you can talk to them about what to expect. Think about trying to personalize their risk, and think about, what is the biggest issue? And many patients will tell you whether they're more afraid of a clot or a bleed. And they'll say, I'd rather have a bleed than ever live with an ischemic stroke. And so it depends on what the individual patient wants. And so in summary, I would say, please try to use an algorithmic approach to this. I think it's very helpful because many of these calls come in nights and weekends, and it's good to have an institutional protocol already in place so that you have a little bit of help in following it. Starting with the standard labs, PT, PTT, fibrinogen, and CBC, if you can get it, and then you can layer in the specialized assays depending on what drug you think may be involved. And while the specific reversal agents are becoming more widely available, you can still use transfusion and these antifibrinolytics and local measures to try to prevent bleeding. And with that, I will thank you.